So you can put your videos on now.
Okay. I'm still facing that message. You cannot start the video because the host has stopped it.
Likewise.
Same challenge?
Yeah, sure.
Right, just a minute.
Same challenge.
Okay, just a minute.
So my name is Muriuki Kevin Tiga, a second-year medical student at Kenyatta University.
We started.
Right now?
Same
Not
thing.
working.
Should we wait for 3, just a minute from now?
Yeah, I think we'll have to wait.
I've already started the meeting. There are 30 people already on.
Not working. It's not working. Okay, let's just. I feel like because of time, we don't necessarily need to have a video function on. If you're going to project the pictures of the speakers or the images of the speakers, that's fine with me.
John, could you enable screen sharing, please?
And guys, please mute your microphones if you're not speaking to avoid the background noise, please. So I think we can leave some time for people to join in. To give time for people to join in. How many minutes?
Like 5 minutes, maybe.
Okay.
Okay. So, um, good afternoon, everyone. My name is Muriuki Kevin Tiga, a second-year medical student at Kenyatta University and part of the MSAKE COVID-19 response team. This marks the third in a series of weekly webinars organized by MSAKE COVID-19 Task Force and partnership with Daktari Online. As one Frederick Douglass said, knowledge makes a man unfit to be a slave. Today's focus is on human rights, which have been subject to violation even during the fight against COVID-19 pandemic. revolving around imposition of public order restrictions to cover public health issue, breach of patient confidentiality, isolation and quarantine, disposal of bodies, and much more. We as the medical students, being the clinicians of tomorrow, we have a role to play during this pandemic in our own capacities when called upon. Before I invite the speaker, there are some few housekeeping rules. Please, as the session is ongoing, keep your microphone muted, and in case of any questions, you send them to Nicholas, and in the format, first the name, first the name of the country, the university in which you study, and now the question. In the question and answer chat box to be responded to at the end of the session. The question and answer chat box is at the bottom of the page. Facilitating today is a Kenyan physician and human rights advocate. Currently, the co-executive director of UHAI Ashri and the vice chair of the HIV and AIDS Tribunal of Kenya. She is also an immediate former CEO of the Kenya Medical Association, KMA. She has garnered several achievements, and among them, the Queen of England's Point of Light 2019, Accountability International Leadership 2019, Top 100 Most Influential Kenyans 2019. Top 100 most, pardon me for that. She has garnered several achievements, and among them, the Queen of England's Point of Light 2019, Accountability International Leadership 2019, Top 100 Most Influential Kenyans 2019, Top 40 Under 40 in Kenya 2017, Aspen 2018 Global Fellow and Fellow of the British Connect Future Leaders Program. Also, she is a holder MSc in Global Health Policy from the University of London, an MBA Healthcare Management from Strathmore Business School, and a Diploma in Reproductive Health from the Geneva Foundation for Medical Education and Research. Born and raised in one of Africa's largest slums, that's Kibera, her achievements mirror the lives of ordinary Kenyans who carve the paths to create their unique niches in the society. Without much ado, and with great pleasure, I present to you Dr. Stella Wairimo Bosire Otieno. Karibu Daktari, the floor is yours. Thank you.
Thank you so much, Doc. First and foremost, these are so many words, yeah? Nicholas, I thought we agreed on Stella Bosire, MD, that's enough. Anyway, it's my pleasure to speak to all of you. A couple of years ago, I was one of you, graduated in 2012, class of 2012, internship 2013. And it's a pleasure again to reconnect with most of you in this webinar. For purposes of stability, I'll be on and off on video. But yes, I hope that we are going to have fun in this interactive session. For the past 15 minutes, I am going to bore you with my voice. I hope I shall not bore you. But just wanted to highlight a couple of things that will actually form the basis of our conversation around human rights in the times of COVID. Thank you. So usually I'm a very positive person, so I'll always start with positivity. When the COVID pandemic began, I mean, then it was just an endemic disease in China. And a lot of people thought China could be able to contain, and there was a lot of confinement of information within the borders of China. And there are a lot of threats around healthcare workers as well as individuals who spoke out against. 4 months later, the story has changed. 4 months later, it's a world pandemic that has killed hundreds of thousands of people and that continues to ravage and infect another millions of people. And despite all this grim situation, there is hope, which I don't think we're paying so much attention around. The hope around two drugs that have been with us for the longest time possible, particularly for people who work or around the tropical area, hydrochloroquine and azithromycin. Hydrochloroquine has been one of the drugs that have been used in terms of management of malaria, and now it's proving to be one of the drugs that is either reducing the severity of the disease and in some cases has shown to have very better clinical outcomes in patients who are in ICU. We are also around a time where, despite there having been shortages of PPEs, we are seeing that the number has started improving. Our frontline workers, who you and I represent, are now accessing better, are being as exposed as the ones in the last few months that we've had. And the best news of all, in the month of April, we began clinical trials for a vaccine among humans. This is going to be a very interesting clinical trial because it will not go through the normal steps around clinical trials where we have to go through animals before we are able to launch the vaccines in humans, because of how this disaster continues to ravage the world. So 3 things that make me smile today: the vaccine, hydrochloroquine, and the PPEs. However, are we where we are supposed to be? No. Just a recap around COVID-19. It's one of the viruses which causes an acute respiratory infection, what we call the SARS. And we've had such viruses before. We had the MERS, which was the Middle East. We have the avian flu, in 1918, we had the Spanish flu. Multiple of these upper respiratory causing viruses which are of a threat to human. And the biggest threat of them, and every time I am asked, why is it that COVID or any other acute respiratory causing infection is a threat, is because of the mode of transmission. That is why we are all panicking, because it's transmitted through respiratory droplets, and all of us are dependent upon air to be able to breathe. Also, a recap, I know you've done this in the previous series around the pathogenesis of COVID-19. The biggest cells it attacks, it's the type 2 pneumocytes of the alveoli. And remember where the surfactant is produced. And that's where the area around the surface tension that keeps the alveoli open. And because of the pathophysiology of release of the cytokines and the inflammatory reaction that ensues, we have, in layman's language, drowning of the alveoli, with a consequence of respiratory distress in most of the patients. Hence the symptomatology around cough, around shortness of breath or difficulty in breathing. And of course, the cytokines also elicit, because of the hypothalamic reflex, they elicit the fever that we have. So that was just a quick recap, but it's also important to mention that while we also know that the first primary area of infection or of effects, pathological effects of COVID is the respiratory system, we have also witnessed severe inflammatory disease with kidney failure among multiple patients. So why is it that it is important for us to address human rights issues? 2 key values form the basis of human rights, and that's around human dignity and equality. But this disease is bringing out to light the inequalities and injustices that have existed, not necessarily within the global front, but even at national levels, where for a long period of time, where healthcare workers have talked about the divide around income, social determinants of health, access to information, gender issues that have a direct effect on how it is that our health outcomes of our patients are determined. And because of this, we also have to remember the importance or the base or the pillars that hold human rights. And one of them that we have to remember is that human rights are alienable. That means, excuse my pronunciations, if there's a place I need to repronounce, you will allow me to. The alienability of human rights means that you cannot be able to lose them. So it's your rights. You're born having, you can be able to command or demand for this. Actually, the English word is to demand. Human rights are indivisible, interdependent, and interrelated. That intrinsically they are connected to each other and cannot be viewed in isolation from each other. So I cannot be able to talk about the freedom of association or the right to health without also being able to look at what are the sub-variables around healthcare that we also need to address. And then there's the issue of universality of health, of the human rights, that they apply equally in every single part of the world. They don't respect race, they don't respect wealth, they don't respect national borders. They are global in nature. That a person who is in any other part, like in Australia or China or Kenya or Egypt, that they actually can be able to demand for their rights. From the days of formation of the WHO, health as a right was recognized to a point that it actually reflected on the preamble of the WHO. So the WHO preamble talks about what health is and says that the enjoyment of the highest attainable standard of health is one of the fundamental rights for every human being without distinction of race, religion, political belief, economic or social conditions. Important for us to underline political belief, economic or social conditions, because part of the things that we are going to delve into deeply around COVID have been reflected on these factors. Article 25 of the Universal Declaration of Human Rights of 1948 also speaks to health as a right. When we reviewed the Convention of Economic and Social and Cultural Rights in 1966, it also still reflected on the same. So what are the key aspects of health as a right? That even as we're having this conversation, it will start helping you think around the things that were even the interventions around clean water, the interventions around hygiene, and why it's very important for us to address. That the key aspects of health, access to health as a right, are anchored around safe drinking water, adequate sanitation, safe food, adequate nutrition, housing, healthy working environments and conditions, and access to education and information, as well as gender equality. Health as a right also contains in freedom and freedoms. And right now, as we're talking about the conversation around, we are going into clinical trials of the vaccine, the issue of non-consensual medical treatment has to come up. The other day you had when the WHO Director General had to give a press conference after some of the French medical or healthcare workers say that they will bring the vaccine to be tried in Africa. And the connotation around that was from a racist perspective. So to be able to remember that consent is a very important freedom from access to right. Then there are certain entitlements around healthcare that we should be able to talk about. The right to prevention, and this leverages on states. Constitutionally, in all the countries that we are in, for instance, if you look at our constitution in Kenya and also anchoring around the Universal Declaration of Health of 1948, the Convention of Social and Cultural and Economic Rights, all of them anchor and put the state as a duty bearer of health around prevention, treatment, and control of diseases of public health interest, access to essential medicine, maternal, child, and reproductive health, equal and timely access to basic healthcare services, and provision of information. So now you understand why one of the reasons that China is being hit on is when it concealed information, important information around this virus that could have saved lots and lots of lives. And this is the only place perhaps I will ever agree with Trump in saying that China refused to release information. Any other thing around Trump and in his administration, I do not agree with. The other important thing that we also have to remember around access to care and healthcare is non-discriminatory, the non-discriminatory clause. We're witnessing world over what is happening around COVID patients. And the discrimination is not just coming from the healthcare workers, it's also coming from our social circles. It also comes from our family members. And this is one of the very important things that I'm thinking we're missing an opportunity for us to learn from how HIV in the last 30, or actually we're going into the 4th decade, how HIV has been managed, how the reduction of stigma index globally has been one of the biggest wins in terms of containing the pandemic to a point where we're looking forward to 0 infection rate by the year of 2030. So discrimination is something that we have to. Of importance, we have to also remember that if we are offering any intervention, it must be available, accessible, acceptable, and of good quality. And that's why in the beginning, when there were publications which were case studies around azithromycin and hydrochloroquine, most of us ask a lot of questions around random controlled trials, because that is the most superior clinical in terms of research that can actually give you better results as compared to case studies. So for us to be able to ask, is this intervention of good quality? Has it been accepted? Right? Is even right now, as you're asking people to be able to use facial masks, is there a community buy-in, right? Because the acceptability also forms a very important basis for public health interventions to be able to be accepted. COVID and human rights. For me to highlight, what are the things that Muriuki, when in his introduction, had already started bringing these issues out in light. The restrictions. It is indeed a no-brainer that for us to be able to contain the spread of this disease, we must be able to contain the movement of people. But even as we curtail the freedom of movement, there are certain things that we must be able to take into account. That the basis of us restricting the movement of people have to be in a non-discriminatory way, and even when it's happening, limited duration, so that we cannot be able to lock people indoors 100%. We should allow them to be able to access basic amenities like groceries, to be able to access healthcare services, and we'll discuss about the impact of the reproductive health and rights on specifically for COVID. And we must also respect, we must also safeguard human dignity, even as we restrict the movement of people. Look at what is happening in some of our quarantine and isolation centers, particularly where our governments are included. We've seen people talk about very dirty environments in places where you are supposed to really contain people for a public health intervention. Hygiene issues have been raised. Abuses, both verbal and emotional, have been raised. Issues around access to adequate nutrition or even access to light have been raised, and not necessarily in Kenya, but in different contexts that we must be able to highlight. So this issue of quarantine, if it's not being looked at closely, will actually form a kind of an umbrella or a cover for a lot of heads of state or government to do whatever it is that they want to do. And we've seen violence also around people, for instance, who are getting home beyond 7 p.m. being beaten. We've seen fractures right now. Hospitals, which are only supposed to, essentially are supposed to be prepared for COVID-19 patients, are now handling patients who are actually have been subjected to police violence. Then the other important thing around what we've seen as a violation that has occurred around COVID-19 is also the concealing of information as it started. The issue of transparency has not access to information until WHO made this a pandemic. That's when we started seeing information around this disease in terms of modes of transmission. And even then, the uncertainties around being a novel virus not being able to be understood. So under international human rights law, governments actually have an obligation to protect the rights of freedom of expression and the right to give information that is sought by the public and to receive this information by all means. So this is one of the weaknesses that we've seen in the public interventions around information. Somebody asked around numbers. Yes, of course. Most governments will always conceal numbers in terms of they will under-report when really this is the one time the people need to be told the truth. In fact, one of the skills that you learn in communication around healthcare is that accurate and timely information is a huge tool for successes of any issues that might be able to come out of any pandemic in terms of management. Then the other thing we have to also highlight are the disproportionate gender challenges that we are having. The other day, I was having a conversation with Atia. Atia was also one of the outgoing leadership around the gender issues. And we talked about pregnancy right now, the threat to pregnant women. Uganda is already recording maternal mortality around women who are prevented to access healthcare services for delivery. We are already seeing in Kenya numbers of women who are delivering within the homes, and some of them who we would medically categorize as having bad obstetric history, delivering in home with 2 previous scars because of one reason or the other one, meaning that the next delivery must be able to be monitored by a healthcare worker. When these curfew times actually become an obstacle to access to health for other emergency services, we are seeing ambulances right now being diverted to be able to handle COVID emergencies, and yet obstetrics and maternal care in this continent remains as a glaring. 2/3 of the maternal deaths are actually happening within our continent, in the sub-Saharan region to be specific. And to have an interruption of how it is the interventions that have already been put into place, then that means that the wins or the milestones that we've had or we've won in the last years, we are going to lose them. There's the issues of a diversion of funding. Right now, most of the funds are being diverted to COVID, and by all means, it's noble. But then we also cannot be able to compromise care around essential services, around vaccination, around obstetric and maternal care, around HIV care. And that's one thing that we also have to take stock, even as we are rechanneling most of our resources to the COVID response. And the other last thing I wanted to also just bring up before we open up the conversation around question and answering is the issue around healthcare workers. A lot of the time we talk about the right to the patient without regard to the right to the healthcare workers. And the right to the healthcare workers actually forms the basis of the success to health as a right for the patient. Right now, world over, we are seeing an inadequacy in terms of access to information for healthcare workers around infection prevention and control. We are seeing inadequate personnel with technical know-how on how to, even when there's availability of PPEs, how they can be able to even use them. We are seeing a lot of blame to the healthcare workers. I mean, we've seen this globally. I mean, even in countries which would categorize as first world, right? Developed world, that there's a shift around victim blaming and the healthcare workers being put central to be able to take up the blame, which is wrong. We are seeing a lot of governments not taking up responsibility around occupational safety and health aspect for healthcare workers. With right now, for every 10 COVID patients, particularly, and this statistics coming from case studies around Italy, 3 of them were healthcare workers, right? And in Kenya, out of those who have been isolated, 4 have been doctors, 10 have been clinical officers, and other numerous nurses have actually been isolated and quarantined after they tested positive. So these are the things that we also have to think about deeply around mental health issues. This is the time where we have the highest burnout levels because we are strained in numbers. I mean, look like Kenya. I mean, look at not just Kenya, the region. On average, we have 1 doctor to about 10 to 15,000 population to serve this. And this means that we are going to really strain our healthcare workers. Are we talking about mental health? We're having acute anxiety right now. We're having depressive symptoms among our healthcare workers. We have an acute psychotic breakdowns among healthcare workers because they're overwhelmed. Overwhelmed coming from the strain within the healthcare system, losing their patient, and they are even themselves. We are isolating our own healthcare workers who are managing patients and keeping them aside, cutting them off from the social support system, which for us is a very big anchor in terms of how it is that we handle a lot of the pressures that we have from work. So it's something very important that we have to address. But even as we look at the violations that are occurring, we also have to remember that freedoms also come with responsibilities. But as healthcare workers, what are these responsibilities that we also have to remember? That when there exists adequate and accurate information around occupational safety, may we be able to follow them for us to protect those close to us, either as family members or also as patients that we are treating. May we also remember to maintain patient confidentiality and privacy right now. People want to conceal the identity of patients. People want to do stories about patients. Do remember to conceal because you're told to do no harm. While it might not be direct harm in terms of physically, but you might harm emotionally in terms of exposing patients in a disease that still has huge stigma and discrimination to the population. It's also very important for us to remember to report anytime we have, we think we have been exposed to a patient who's suspected, because then it is that we are protecting the public as well as protecting those who are around us. So I'm going to leave it there, and I'm going to address the issue of death as we finalize the conversation, and say, let me take a break, have some water, and then take in questions.
Okay. Okay, thank you, Dr. Basira, for that wonderful presentation. My name is Pavanrat Singh Chana, and I'm a 6th-year medical student from Moi University. As we have seen holistically, various public health measures, expanded government powers, the disease itself and the management approach has brought a dilemma of various human rights issues. So I will just take a few questions from the Q&A chat box. They're not that many, so we can just ask them through and you can add on to whatever you deem fit before we conclude the session. Is that okay? So my first question is, the first question is from Nasir. He's from Maseno University. He was asking that, in your opinion, when do you think these restrictions from the government will come to an end? And how many months do you think it will take? It's a broad question, but you can just give your opinion.
Oh my God, that has to, I have to put on my epidemiological biostatistics. We're assuming, within the African continent, we are very lucky. And I've talked about the positive things that we are already seeing. And one of them is we are now accessing PPEs, right? We are doing mass testing. We are intensifying public health interventions or messaging around hand hygiene, around face, around use of masks. So that means, in my belief, that the impact of this disease within our region is going to be not as harsh as what we'd expect. Also, we do not have the luxury to be hit hard. Our healthcare system cannot be able to take up the strain. So we should brace up to June for us to contain this to where normalcy. And I don't even think there's something like normalcy post-COVID, right? We have to really reevaluate how it is that we prioritize healthcare, how it is that we budget, what are the priorities in terms of leadership, how is it that we work transnationally around interventions in responding to pandemics. I mean, nothing will go back to normal, but wherever it is that we'll pick it up, I will tell all of you to brace until June.
Yeah, at least some glimmer of hope. Another question from Omnia Bakri. He's a second-year medical student from Aftad University from Sudan. He's asking, what are some of the reasons for women being discriminated?
So there are multiple factors. I didn't discuss, first and foremost, may I take this moment to trim the fact that 70% of frontline healthcare workers are women right now globally. 70%. So we are missing our homes. We are not staying with our children. We are missing the most important component of our lives, which is our social system, right? Because one, we are at the healthcare, we are at the front line. So the other way I would want to look at that question is in terms of the discrepancies that exist. One is around the heightened level of gender-based violence. We've seen, because people are spending a lot of time together, so defilement and sexual abuse has actually been on the increment globally over. In fact, in Kenya, our judiciary had to do a press conference around the number of cases which are being brought forth. I work for a human rights organization where we give grants around vulnerable population, women being one of them. We have gotten the highest requests around being able to give money for safe houses because of the violence that has existed. So in terms of, when you're looking at it from a social perspective, those are the issues that are coming out. But from a biomedical perspective is the increased risk of having women in the front line, but also the issue of the disparities that have chronically existed in medical research, that most of the drugs in terms of the dosages, most of the interventions, even on vaccines, are hardly tested on the women, they are tested on the men. And physiologically, we are totally different. So we realize that even some drugs which are being rediscovered, which are being going through research again right now, do not necessarily fit on my physiology as they would fit on the XY individual, right? And those are the things that are coming and are being highlighted right now. And also the economic, the ability to make decisions. Look at who are on the front line right now, right? Except the European countries where we're seeing the containment of the virus. Globally over, we are just seeing a face which is being presented as a male, which is chauvinistic, which is very militial in terms of how they are pushing for these interventions, because the force that we are seeing is actually a reflection of the leadership that exists, that the police brutality is a reflection of the leadership that says, if people are not in their house by 7 p.m., beat them, lock them up, you know, and it's a reflection of the leadership. So we also have to remember that in a better mix of healthcare leadership is bringing in different diversity in terms of genders to be able to hear the different voices and to be able to bring the compassion that, for example, the women bring on the table, to be able to bring in the sick makes sense that the women bring on the table, even with their intellectual capabilities, to handle the pandemic.
Okay, yeah, I agree. And testing of drugs really needs women to be amongst that sample size because of teratogenicity, scares and the likes. So I'll go on to the next question. This one is from Faith Chepkirui from University of Nairobi. She's asking, there is an increase of domestic and gender-based violence at the moment, especially with people being told to stay at home. And I'm sure there's a lot of stresses and resource depletement and the likes. So she's asking, how is this supposed to be handled? And apart from the toll-free numbers available, is there any other rescue centers or helplines available?
Okay, so I have multiple resources because my work around human rights has always been from a reproductive health perspective. What I can do is share with Nicholas all the resources available within Kenya, and I will look around my space within, because I also work in the whole continent, and see what are the opportunities available that we can share within our spaces. But indeed, there is help. If you're stuck with somebody, I mean, you guys have my number, please call me and I'll be able to refer, even if I'm putting the resources together. So I will share that as a resource.
Okay, that's perfectly fine. And I'm sure they'll understand why that question is. The next one is by, where is it? It's by Angela Gisharu. She's from Mount Kenya University. She's a fifth-year medical student. She's asking what can be done for the homeless who have no money to access healthcare, tests, and even drugs itself.
When Moruki introduced me, he said, part of my childhood, I spent half of my childhood as a homeless child, right? Living in the street with my mom. And yesterday, my colleagues and I went to the streets to speak to the Kenyan public, particularly those who don't have the privileges or who don't exist in the spaces that we exist around public health interventions in COVID prevention and control. And the most heartbreaking thing around that is witnessing a middle-aged mother with a small child, the hygienic situation around her, while wanting, and then we were there with our multiple degrees telling her about hand washing. And, you know, I stopped. And I was like, no, that's not how we're supposed to do it. So the question I asked her is, do you have soap? She said, no. So we bought soap. So do you have detergent in the house? Do you have like disinfectant? What disinfectant? We told her, Jake. And we're like, any hypochlorous disinfectant can be able to help you clean your surfaces, because she has a small child, barely 1 year old. She represents 70 to 80% of Kenyans in this, I mean, and a huge population within the African continent. And that is the one gap that the government is not being able to intervene in. That even if we were to get to 100,000, our Achilles tendon within this pandemic exists in those who cannot be able to afford the things that we are telling them to afford. We're telling them to stay at home. Are we giving them food? We're telling them to wash their hands. Are we giving them soap? We're telling them disinfect your surfaces. What does that even mean? You know? And that is a one place, if you're not careful about, we will. So the homeless right now, if you know anybody and you live within, I mean, and this is an appeal, a heart-to-heart appeal. This is the face of humanity. This disease will actually separate the chaff, you know, from the wheat, because it will say, how many of us are compassionate about how the situation, how deplorable life is? If you can change one life, please go ahead and hold someone's hand. Even if you're putting them in your SQ, even if you're giving them soap or sanitizers or a blanket or whatever it is that you can help them with to be able to reduce their chances of contracting COVID, please do that. Because it takes you and me to be able to make this difference, even as we make noise in the big spaces that we sit in.
I agree. I totally agree. I mean, we have the same dilemma. We take care of street youth in Eldoret, and we're discussing various ways on helping them, but there's a lot of government blocking and a lot of issues around that. But that's talk for another day. There's another question by Nyakio Buru, also from University of Nairobi. So she's asking, without overlooking today's COVID-19 topic, I would just like to inquire into why 2019 was such a year of prolific recognition to you as an individual. And what with all the local and international awards have you been doing in the past years to get such an inspiring status as a highly influential Kenyan medic? So that's just to break the ice and
yeah, to stop discussing the disease. Well, maybe Muriku just focused on 2018, 2019, but I have just been very privileged from when I was in medical school to have taken up very senior leadership positions in this country around healthcare. Having come from a community that I came out from, I have always been very vocal around social determinants of health, particularly affecting slum dwellers, because that's where I've actually spent half of my life, no, 3/4 of my life there. I literally left the slum when I got my scholarship to go to medical school. And that didn't stop me from being able to highlight issues. And I've also stood up on credible and integrable leadership. Before that question hits me, I don't believe in serving systems which are broken, systems which do not have no regard to human rights, systems which are discriminatory. And that is why some of the senior positions where I have been appointed to in the current government, I have rejected them. And my work around human rights has always touched on vulnerable populations and has always been women, has always been LGBTIQ community, has always been adolescents and the youth. And because when you live at the edges of the society, but there's a vulnerability presents on itself and breaks you down that you even lose that voice. So for somebody like me who has been through, having lived the life that I've lived as a young woman, and also just being privileged to have gotten into spaces and to get the education that I've gotten through scholarships, it keeps reminding me that the work is not yet done, that we always have to go back to be able to change the situation. And when you do good things, maybe somebody sees you, the Queen of England sees your good work, the International AIDS Scientific Conference committee sees the good work that you do in your research, in your social advocacy, and they recognize you. And I guess that's why these things have happened. Yes, but I'm forever grateful and forever privileged and humbled for them.
We all are, and hopefully we can take up such lifestyles and such inspiration. So there's another question on, okay, with the issue of isolation and quarantine. There was a question, but I'll just combine the question. So it's one of the most appropriate responses for this pandemic, and it's obviously causing a conundrum, especially for those hand-to-mouth populations and those unable to work from home. What do you think are the human rights issues with this? And apart from the economy being affected both individually and nationally, what do you think is the best way to approach this? Because we were also promised, children were also promised the internet education, but they've not yet received that. So there's a lot of denial of right to education. And also, if you have a mild case, you can't really go to a clinic because everyone is getting scared of what you have.
That's a very emotionally draining question. Emotionally draining in the sense that we're a country where 50% of us are living below $1, and I speak in the Kenyan context. And we're a country where 60% are unemployed. And in the 40%, only up to 20% are employed within the formal sector. And the cushions that we thought existed even within the formal sector we've seen people getting salary cuts. We've seen people losing their jobs, right? Because companies are folded. Shareholders are telling them, we don't want to lose our money, so fast cut off. So your first point of the first place that is being hit is there in terms of is a staff. So we are seeing people who you would classically even categorize as middle class having to be reduced to the lower pyramid in terms of right now they're struggling in access to food, access to clean water, access to electricity. I'm not even going to touch internet and books because that's a whole big problem that we also have to address, because that also addresses issues of corruption. The other day, I don't know if all of you were watching television when Raila went to Kibra. Kibra is where I grew up. And they were distributing food. And people were hurt because they were all scrambling for this food that he brought. Kibra has on average, 500,000 to 2 million people. And you tell them we are coming to distribute food. How are you going to feed these people? So the lack of proper leadership in terms of planning on how food can be distributed in an organized manner that also still dignifies the human, because what we witnessed, the fractures that we saw from there, the women who were hurt, the children who were hurt when they were scrambling for food, tells you that there is a desperation that exists. In South Africa, what has been witnessed is when the government called a lockdown, crime levels shot to the highest level. Why people's houses are being broken into, supermarkets are being broken into, because people are panicking. They're wondering what will I eat tomorrow? So this is a time that calls for a well-coordinated mechanism using all the structures, governing structures that exist, to the lowest level of a ward, to the highest level of the nation, to be able to ensure that the vulnerable are mapped out. Because that's one thing that our government has not done. Mapping out the weak people within, the elderly people, the children within this, and starting to give rations within these populations and climbing up as their availability of resources. Right now, we have R1 billion that has already been raised in the government kitty for COVID-19. I am just looking at a point where, and I'm saying, if nobody's going to take the government to court, I will take the government to court around accountability and transparency on utilization of resources around this COVID, because somebody has to answer for it. People are struggling right now. Kenyans are saying, let me die of coronavirus, then sit at home and look at my children dying of hunger or crying of hunger. And honestly speaking, having come from that community, even when you were sick, you would get a point and asking yourself, do I go to hospital or I eat? And that is a point we have reduced our Kenyans to. So in the spaces that you sit in, the one thing that is also going to help us as an indirect, that has an indirect effect in combating COVID, is being able to address the social needs.
I totally agree. And it's just a funny dilemma that you can be, okay, you're never supposed to be corrupt in any circumstance, but especially at this time where people are relying on you and there's a lot of pumping in of resources and money being donated sincerely by multiple parties, you should at least use it for your country. And I mean, if there's no people, there's no future. And what are you going to do with that money?
Indeed.
So there's another question from Bridget Ogega. She's from University of Nairobi. She's saying, what next after this pandemic, and what are some of the things that, as an advocate of human rights, would you like to uphold with greater zeal once we begin healing from this and once this is over? Tricky question.
It's a tricky question, and I'm going to address it from a health systems perspective, right? And because I know in the next couple of months, I mean, like you, Doc, you will be joining the workforce. The next time the government tells me we are not hiring a doctor, I will I'm not going to curse, take them to court. If there's any time where our governments have been naked, literally the king has been naked, it's now, right? We have 250 ICU beds in this whole country. If we had 1,000 patients who required respiratory support, as Dr. Bosire, I will be required to make a decision between which life to save and which one not to save. I do not want to ever find myself in that situation. But the reality is, before COVID, when I was in clinical practice, and that is why I left, I found myself in that situation. And yet every single year, we see reallocation of resources to health. And every single year, the Auditor General gives us a report of misuse of resources. And one of the areas that bleeds the most in corruption is healthcare. The other thing is, I am literally going to look at Kenyans or people of this African continent and ask, when you go to the voting, when you go to that voting board or cube, please think deeply about the person who will literally represent you and representing the needs of the population. Yesterday, some of you who are watching news, you saw Adam Duale in all his awesome or non-awesomeness on national television saying, I do not want my salary of 1.3 million, which is about $100,000, being about $10,000 being reduced. Why? Because I have other needs. People who put their own needs, this is a political leadership that puts their needs ahead of the other people. Why would we want to have such leadership? In fact, COVID-19 has taught us one thing. We just need a handful of representation. And the other thing is a challenge. I feel that if right now I was to take up a political leadership position, I would heavily fundraise, I would heavily campaign around health as an entry point to being able to solve most of the problems, either from an economic, from a leadership perspective, because health anchors everything. We've seen the Prime Minister of Iran die of COVID, right? And in the beginning, they didn't talk about it, or they rubbished it. People who went online and talked about this pneumonia, this disease that is killing people, they were jailed. The same thing happened. We lost a 34-year-old doctor who brought COVID to the global space. Because of what? Of a leadership that decides to conceal information, that decides to violate access to information as a right because of their own incompetencies and their own inadequacies. So we really have to think about where our health systems, how it is that we're going to address the health system brokenness, and how it is that we're going to look at the leadership moving forward.
Okay, so to add on that question, I just wanted to ask you, like, because of all these, because of this shifting attention and all these issues, altering our livelihood, human rights, and even those people protecting them, including the labor union staff, the environmentalists, the people who are involved in anti-corruption processes. These processes can be bypassed. And do you think that in a pandemic where there's still risk of infection and like just cross-infection in these essential services like institutes, that these people should still be present and still be treated with the same way as healthcare workers, because they are not only risking themselves, but they're trying to protect not the population health-wise, but yeah, because they contributed, it's their tax, it's their environment, and apart from having a problem right now, we might have even a problem in future, and the sustainability issue rises.
Indeed. I think those are some of the important things. I mean, the other day, yesterday actually, Johnson Sakaja, the senator for Nairobi County, tabled a bill in Parliament, and one of the things that was being discussed around rent freeze, around freezing the unlawful laying off of workers, was discussing about accessing social, like government literally availing food to people, and we are hoping that this bill will go through to law, right? Because it's actually anchoring on the Public Health Act, because it's feeding on the successes of this act, because it was evoked by the ministry and by the government. The success of it is not dependent on just asking people to stay at home, to isolate, to quarantine, to manage, and to practice hygiene. It's also looking at the economic effects and being able to address them. So we are looking at harder times ahead. We're a tough nation. We're a tough continent. We'll survive. I'm always hopeful. I always have this positive belief that everything will always self-correct and work out. But we also needed to pause about the priorities that we have as a nation.
Yes, I am too, but sometimes reality just tells you otherwise. I know. There's another question about by Faith again. She was asking about healthcare administration and management. Do you think having doctors as administrators is an advantage? Should they be given the complete role of authority?
I think it's an advantage. I have been, in my previous roles, I've sat in management positions, both in private and public sector. And there's one thing when things are being discussed theoretically, when somebody tells you, oh, buy masks.
Yes.
And you tell them there's a difference between buying a surgical mask, giving a healthcare worker who is screening patient a surgical mask, as compared to giving them an N95. So when you sit in that room and you understand about the viral particles, you understand the micron, how small the virus is, and the protective effect of an N95, you will advocate for the first person who's screening a patient to actually have an N95. That knowledge does not come easily. So when you sit down, for example, in procurement, and people are saying, oh, let's buy amoxicillin or amoxiclav, which is a combination that is constantly used for most of our, it's like a first-line penicillin-based antibiotic, which is clavulinic acid and a penicillin. And somebody says, oh, no, let's buy ceftriaxone, right? And ceftriaxone is a second line. For example, if you have a Quincy's abscess, for instance, right? And we give you an amoxiclav, which is a peritonsillar abscess, and it fails. And you tell these people, no, if I was to buy, I would actually buy amoxiclav and then I'd prioritize amoxiclav because resistance in terms of resistance profile, because you're also thinking antimicrobial resistance before you are able to bring in the big guns, which are the ceftriaxones. A layman would find that a very difficult way to be able to reason. And this is my encouragement to all of you. If you have resources and you have time, even if you're going to go into clinical practice, because at a particular point you will manage your institution, you will manage your patients, please do a course in management, even at a diploma level. There are certain skills that I gained from Strathmore. I went to Strathmore Business School for my MBA that I never gained from medical school. But then the marriage between the MBA and the Bachelors of Medicine and Surgery and the skills, the combination of those skills have made me a better clinician in terms of looking at management and looking at healthcare from a different perspective. So I would literally encourage all of you to be able, if you can, to do that. So management, yes.
No, I agree. Even many universities are taking up that as a course, which is going to help us like immensely. Kevin Kipkoech asks, do you think we are being so harsh to the government about being more judgmental on its actions, basing on the fact that there is so much like civil disobedience?
Is there something that we are saying right now that we have not told the government around healthcare and the systems?
No, really.
In 2017, doctors went on strike for 100 days. Nurses almost got to our 100 days. Cumulatively, we had about 200 lost days of work for healthcare workers in 2017. And what we are discussing right now, how broken the system is, the number of healthcare workers, the lack of investment in technology and in training are things we've discussed. Can you imagine if this pandemic came in and we were prepared? And prepared from the frontline workers, prepared in terms of availability of essential medicine, because even if we right now have hydrochloroquine, symptomatic management of patients is still the cornerstone of patients who are recovering. So we are managing fever, right? We are managing dehydration, right? We are dialyzing patients who are going into acute kidney failure. Those conditions that we are managing literally are consuming essential drugs, which we have not been having and which we still don't have. So I don't think we're being harsh on this government. I think we're telling them what we've told them. The only difference is that right now they are experiencing what we've told them. It was not theoretical, but right now the practicality of the things that we've told them over and over is becoming a reality to them.
I agree. Okay, so as we await other questions, I know we were supposed to ask this last, but I just wanted to bring in the issue of, just the burial of dead bodies. So what do you think, like, there are a number of questions that have been asked, but just to summarize them all in one take, do you think, how do you think it's supposed to be handled? Like, observing the distressful and grim mortalities Italy's faced and other countries are maybe yet to face, what are your sentiments on how news should be disclosed with doctors being being overworked and handling so many patients? And then also about disposal of bodies and even funeral procedures. These are important sentiments to many cultures. and some people are not able to respect those. And it's very difficult for someone to even articulate how someone has just died out like just suddenly.
First and foremost, if you belong to the community where the man from Siaya was indignified in death, I am really sorry. As Kenyans, we ought to be ashamed.
Yes, that example was brought up.
It's sad because a Kenyan did a comparison, brought in our first patient, may their soul rest in eternal peace, who died of COVID, our first mortality, but the death was very dignified. And then this second death, how this body was disposed, it was really sad. These are the facts that exist. In fact, I wrote them down. Only the lungs of patients with pandemic, historically, only the patients with that who have had like a postmortem done and their lungs opened up are the ones who we should actually think about can transmit, right? But otherwise, cadavers don't transmit diseases. To date, there is no evidence of a person having become infected because of exposure to bodies who died of COVID-19. And that's a WHO fact. And I'm referencing to WHO on this. The thing around the recommendation that WHO is giving around disposal of bodies lie in, can we have dignified death, recognition of culture and religion and traditions? That even as we are disposing bodies because of this disease, we are also cognizant of the fact that people have to mourn. Let them mourn. Give them masks. Give them gloves. Let them stay at a distance. But do not indignify them. Authorities need to be able to manage case-by-case situation, balancing the rights of families and the need to investigate the cause of deaths and exposure to infection. That is a cornerstone. That if Stella wants to view the body of her mother, please allow her, but also talk to her about infection control. Tell her you cannot touch the body. Tell her you can only view, tell her you have to wear a mask, right? And ensure that if I have a grandmother, she's not, or young people, young children who we are still studying, that they are protected. They don't interact close to the body. But let's respect even the dead.
I agree. Even from past wars and the likes, where they had such numbers, the rising issues that came after that, from family members being depressed, and also many people believing in superstitions on how their loved ones weren't given a proper farewell, sort of like haunts them and brings other problems, which is not good for anyone. Yeah. So there's just a question from anonymous attendee from Thailand. She was just, I don't know whether it's he or she was asking what would be the best way to balance between the economy and COVID-19? Do you think
I don't think right now we have such a balance, to be very honest, very candid, right? Yeah. That any resources that exist in this world right now should go towards protecting the people, right? The world over survived. There was, when was it? In 2009, remember, globally, the economy sank, but they rose. If the right environments are going to be provided, these are government talking about issues of taxation, issues of tariffs, making environments conducive for businesses, we shall rise economically. But if we lose our life, we shall never regain it back. So all investments right now should be channeled towards taking care of people, should be channeled towards feeding people, ensuring medical supplies, providing PPEs, ensuring that those ones who are quarantined, they are able to they are being treated with dignity, ensuring that access to information. That is where our investment right now is supposed to be.
Okay. So I'll just ask you these questions, and I'll try to combine them because they have a sort of like tandem. What are the possible ramifications of America withdrawing support to the WHO with Trump's sentiment about how they're major contributors, and he's not so sure about them.
Let me correct that. Let me correct that. Trump has always had a problem. I mean, since Trump's administration came into office, it's always had a trouble, always had problems with WHO, right? I remember in New York, in New York, we actually had to literally go protest against a push by Trump to be able to introduce certain languages around sexual and reproductive health and rights to prevent women from accessing family planning, a big pillar in reducing maternal health care, access to safe abortion services. And we were like, no. So this trouble is not now. It's not a trouble that has begun now. FYI, by the way, everyone, for the last 1 year, the US government has not given any money to WHO. So the other member states. But if you look at the historical formation of WHO, you will see how powerful the US government is in terms of the structure that existed when WHO was being formed. But as the world is changing, as more philanthropy is coming in, we are seeing that the gap that WHO is leaving by today, there has been tremendous fundraising globally for WHO. So yes, there's a place in terms of infrastructure, in terms of science, in terms of research that the US holds, but then that also cannot undermine the place of autonomy of WHO, or even as an infrastructure that exists to support its member states. So the US is not the only member state that is supported. So I don't think you should worry. My opinion. Yeah.
Yeah, but the same administration has also withdrawn contribution to US aid, which is very helpful for many vulnerable populations. And so that brings me to the next question. And one of those vulnerable populations are refugees. And Nyakam Sankara from University of Bamenda from Cameroon, third year medical student, is asking, it sort of ties to that question about street population, but also she would like to know how volunteers can limit the spread of COVID-19 in refugee camps, since they're living very closely and the virus can easily spread around. They have rationing points, they have gatherings on how to receive information. They don't have the technology we have. And also they have the issue of now being deprived a lot of economic contribution for those same things. I know the government and the UN, the NGO bodies should have given these people the PPEs, but they're also shifting attention to other areas, and there's also a myriad corruption
I know
issues.
right now, part of, because I also belong in philanthropic spaces, part of the conversations right now is around support for vulnerable populations who are, for example, in refugee camps. And it's thinking beyond the normal humanitarian support that they get and thinking that they need to be protected. So in terms of, hygiene practices, surgical masks, the health centers which are located within refugee camps have actually been revamped. Some of them have already received COVID testing kits. In some areas, there's testing that has already begun in some border areas. Like I know for our border, we already have documented cases, and it's only out of intensified case tracing and recognition and diagnosis that we are able to protect them. Also, the people who keep living in and out of the camps are also a danger to the people who are confined, because they also must be able to regard the public health interventions for infection control, not to carry the disease from outside the camps to the camps.
I agree. So before I ask you the most wanted question, I'll just ask you the last one. And that one is still by Faith, being very active in this discussion. She's asking, with the economic compromise in place, people not working, a big population are not working and being productive. Do you think there'll be laws to protect those people when they get back to work? Do you think they'll be overworked? Do you think they'll have justification of being overworked, or they'll be told, no, you got a break, and this is how we're going to try to financially get back?
Our constitution is very protective. Our labor laws, Article 45 of the Constitution of Kenya, we have our Labor Laws Employment Act. We have our labor court, which is still functioning. There's a new bill which is being introduced by the Senate. If it goes on, it goes to protect. So I want to believe that This already we have existing laws which are very protective, right? But we also have new laws which are being introduced to be able to fit into the current environment. And I want to hope that this government will for the first time do a same thing and pass it to law.
I agree.
Yeah.
Okay, so that brings us to that question I was trying to highlight and try to like upscale. So there's no drum roll, but what do you think the role of medical students are in this, in healthcare and advocating for human rights during this pandemic? And what do you think they will, how will it play out when it's over also?
So two things, actually three things. The first thing from my opinion is that you guys stay put.
Yeah, I agree.
But you live within communities, right?
Yeah, you don't want to.
Do your advocacy within your communities. The finalists, because you're seeing a pattern world over, and I pray that we don't get to that point, the finalists, they might have to, there's a thought around acceleration of your graduation, right? There's a thought around that. If it comes to pass, welcome to the profession. But you coming into diving into the deep end. Where we are right now, the numbers that we have, we even still have doctors on reserve, right? Second line, like we are not constrained. We just fear the inevitable. The other thing is, please take care of yourself. This is not one of the most interesting times. I was talking to one of you, like I have been in medical school for 8 years. Man, that's a lot of years for a 6-year program, right?
That's what's going to happen to us.
I know. And I'm here thinking there cannot be another addition, right? And even as people are rethinking right now, the other sector that needs to rethink is the sector of higher learning. People have done assimilation medicine and done surgery distantly, right? So we can, and most of you, by the time you're finalists, your interaction with patient has matured so much that the next 4 months should not be the reason why you do not finish school, my belief. So ensure that, as MSAKE, this is what I would advise. Can you, all of you, write to the university, unified as a medical students, and give recommendation to the university about how you want your learning to continue and why it is important for learning to continue distantly. Because I mean, look at the numbers we had today. People can access the internet. Notes can be shared on email. People can have discussion groups online. You can actually plan a discussion group on our webinar, right? So there are multiple opportunities around that. But the most important of all, this shall come to pass. The Spanish flu in 1918 came to pass. This shall come to pass. We are better. Well, we're not the best prepared, but we are better off than where we were than 1918. The avian flu came, we survived it. You guys will survive. And the final thing, there is no particular place in this earth where it will ever be written, I am an MBCHB graduate of 1992. The moment you have your golden name tag, that's it. That is the most important thing. That it doesn't matter how long. I hate that you guys have spent so much time in school, but I also believe that it has built such resilience among you that is, you will need this resilience. You will need this resilience when you come and see patients. You will need this resilience in the days you'll be called, you will do 7 or 8 cesarean sections alone at night. Because you're already building a muscle that would not otherwise having been built. And while the times are hard and difficult, there's also a silver lining that you're better off prepared doctors right now than any other year, I think so, than I ever was. Because you've seen through what trouble, what problem systems are, and you've seen through why it is important to do self-care and how it is that you're going to implement some of these skills that you learn in the future as doctors, or rather, you're already doctors.
Okay, so I think I'll hand over the floor to you one last time to conclude, and I'll thank you again for this amazing discussion. Because I'm being pressed on time, I would, and there's one question which keeps emerging in the chat box about the whole issue of now with this speeding of clinical trials and various sections being skipped. Do you think there's are we overstepping human rights? Are we causing another problem? So you can answer that in your conclusion. And
I will type that answer because it's also it's a catch-22 situation where it's a good thing that we accelerate, because if there's hope, let's mass vaccinate. But then there's also a thing around the bioethics of research, and this is harm. What if, because I mean, if you look at clinical trials, you start animals before you get to the humans. So we've skipped to the humans because at the animals we'll realize the adverse effects are able to be picked. So what if these adverse effects actually show up with the humans? So those are the other things that we also have to think about ethically.
I agree. Okay, so you can conclude, and then I'll hand over. Then we can hand over to Christine, who I think will give you a vote of thanks. So thank you, Dr. Basiri. That was quite amazing and inspiring, and I'm so privileged to have this discussion with you, and I've learned so much. You're such an amazing, inspiring, and credible person, and I wish you the best in your endeavors, and I hope we come out of this stronger and more consciential about how things are supposed to be. So thank you, Doc.
Thank you too. Thank you also, everyone. It's always heartwarming. Yesterday I was speaking to Atia and I was telling Atia, I think one of the best things that for me, even as I left KMA as a CEO, was just to bring in the MSAKE in the National Governing Council meeting, because it's the first time we had medical students coming in and sitting with a council of senior doctors and voicing and being able to be involved in decision. And I've seen how MSAKE has grown, how you guys are taking up leadership. There's only one fault. I want to see more women being pushed in your senior leadership. And I know you guys already promised that on a change in the constitution, so that there's also that balance, right? But I'm really proud of what you guys are doing. If there's any other way I can get more involved, I can support your work, please reach out to me. I'm always available.
We will. And yeah, Atia is in my class and she told me. So thank you, Doc.
Thank you too. All right, people.
Okay.
I'll hand over to Moryuki. Is it Moryuki or Christine?
I think Christine, yeah. Christine can just turn on her video. I'll switch mine off.
Okay.
So thank you so much, Dr. Bosire, and thank you, Chana. So my name is Christine Mutonyi. I'm a level 5 student at Kenyatta University, and I'm also part of the MSAKE COVID-19 task force. And I must say, it's such a pleasure, it's such a joy to listen to you, Dr. Bosire. I just want to thank you so much for giving us your time, for giving us your insight, and basically for sensitizing us on this aspect of human rights, and to just empower us to become champions of human rights, not just now during this COVID-19 pandemic, and even later when we become doctors, when we become administrators, or wherever we'll go and whatever we'll become. So thank you so much. And I'd also like to thank Daktari Online. Thank you so much for providing us with this forum. You have been invaluable in the facilitation of this webinar, in just allowing us to use this Zoom platform, and we look forward to even working with you even as we continue to improve healthcare in Kenya and in Africa, yeah? And also I'd like to thank the MSAKE COVID-19 task force. They've been putting in a lot of hard work into ensuring that we as medical students are in a position to respond to this pandemic, to help and to just get our voice heard even in these times. And yes, so I'd like to thank them very much, most especially the subcommittee which has been organizing these webinars. And I would also like to thank each and every individual who attended this webinar. I'd love to appreciate the fact that we have students who are not just from Kenya, from SAKE, but also from Tanzania, Burundi, Sudan, Rwanda, Cameroon. I've seen even Thailand, Spain, and many other countries. And that just shows how important it is for us to work together as a community, not just within the same region, even the entire world. And I think that's something that leaders like Trump are missing, because they don't understand that, you know, WHO is there to serve everyone, not just us, even them. And you know, we should all be involved in matters that affect all of us. So thank you so much for everyone who has attended. Thank you for all the people who've asked questions, for ensuring that you get I hope that everyone has gained. I hope that everyone has learned something new about COVID-19 and about human rights today. And it's important that we remember that the society looks to us in this fight against COVID-19. And we must be well equipped and well informed and have the latest information, and most of all, be bold and outgoing to help however we can. Yes, so just a quick reminder to all of us, let's ensure we fill the feedback form. It will be sent into your emails. Give your comments about this webinar. Your feedback is much appreciated and highly valued in the continued efforts to organize such webinars. And the MSAKE COVID-19 task force continues to create more opportunities to engage medical students in this fight. So let's all keep our eyes peeled and participate when called upon. And, as always, wash your hands, stay safe, and, let's fight COVID-19 together. So I'd like to wish all of us a good day, a good week, and thank you so much. The meeting is over.